Hi there, this is Jeanne E. Poole, Editor-in-Chief of Heart Rhythm O2. This is the May 2024 podcast. We have a great lineup of papers for this month, and I will be briefly reviewing these. The first paper is titled Pulsed Field Ablation for Repeat Procedures After Failed Prior Thermal Ablation for Atrial Fibrillation by Dr. Jens Maurhofer and colleagues. The objective of this study was to summarize the author's initial experience with patients undergoing repeat procedures using PFA. 186 consecutive patients with arrhythmia recurrences after a prior thermal ablation were included and underwent multipolar PFA catheter ablation. They addressed reconnected pulmonary veins, which was the case in 35% of the patient. Additional antral ablations were applied in 49%, posterior wall ablations in 67%. Major complications occurred in one patient, which was a TIA. Total rate then of major complications, 0.5%. Freedom from arrhythmia recurrence in the Kaplan-Meier analysis was 78% after 6 months and 54% after 12 months. The key findings, as the authors state, are that 1. In patients with recurrence of atrial tachyarrhythmia after prior thermal ablation, pulsed field ablation for repeat procedures is safe and versatile. 2. Pulsed field ablation in combination with 3-dimensional electroanatomic mapping for repeat procedures is efficient with relatively short procedural times. And 3rd, further investigation is needed to gain a better understanding of the role of pulsed field ablation for repeat procedures, especially in comparison to radiofrequency ablation. The next paper's title is Identification of Epicardial Connections Can Improve the Success Rate of First-Pass Right Pulmonary Vein Isolation by Dr. Tadashi Wada. The purpose of this study was to evaluate the usefulness of the author's new pulmonary vein isolation strategy with identification of epicardial connections. 253 patients were studied. High-density mapping of the left atrium was performed to identify the earliest activation sites before PVI in all patients. If early activation sites around the right pulmonary vein carina were identified, they ablated those sites and performed first-pass circumferential PVI in 78 patients. They also had another group of 115 patients who had ablation done without the information regarding early activation sites. Evaluation of the high-density maps identified the early activation sites around the right pulmonary vein carina in 10.9% in all patients. Amongst the patients where the high-density information was used to guide the procedure, early activation sites were present in 12.8%, and they were present in 9.6% of the patients where the information was not analyzed prior to proceeding with the procedure. The authors found that the PVI success rate was higher in the group where the early activation site information was used, with a 93.6% success rate compared to 82.6% in the comparator group. The authors conclude that identification of epicardial connections before ablation increases the success rate of first-pass right PVI. The title of the next paper is Sex Differences in Achieving Guideline-Recommended Heart Rate Control Amongst a Large Sample of Patients at Risk for Sudden Cardiac Arrest by Dr. Valentina Kutivia. The purpose of this retrospective study was to evaluate sex differences in achieving guideline-recommended heart rate control during up-titration of heart failure medical therapy, as assessed while patients were using a wearable cardioverter defibrillator. 21,440 women and 17,328 men wore the vest between 2015 to 2018 and form the population of interest in this study. Data from patients fitted with the WCD from 2015 to 2018 were obtained from the manufacturer's database, which is ZOL. The target heart rate was a nighttime heart rate of 70 beats per minute. Among patients who did not receive a WCD shock, over half had insufficient heart rate control at the beginning of use, in 59% of women and 53% of men, and at the end of use, in 43% of women and 36% of men. A further observation was that compared with men, more women receiving WCD shocks had insufficiently controlled heart rate in the week preceding the VTVF. The authors conclude that a significant proportion of women and men did not achieve adequate heart rate control during a period of medical therapy optimization. The authors also conclude that the WCD can be utilized as a remote monitoring tool to record heart rate and inform adequate up-titration of beta blockers, with particular focus on reducing the treatment gap in women. The title of the next paper is called Is Interventional Technique better than traditional over-the-wire method for left ventricular lead implantation in cardiac resynchronization therapy by Dr. Frederic Noregaard-Jacobsen. In this study, the authors investigate the benefit of using what they call an interventional CRT approach, which is a set of sheaths provided by Merit Medical. And they compare the period of time between 2012 and 2015 when they were using the standard sheaths provided by each manufacturer compared to the years after 2015 when they used the sheaths provided by Merit Medical. It is notable that 99% of the patients in the ICRT group, or the more recent group, were quadripolar leads in 99% versus 55.3% in the standard group. What the authors find is that optimal LV lead placement was achieved in 82.7% of the ICRT group and 76.8% of the standard CRT group. This was a p-value of 0.015. They also found that 2 or more leads were used during the procedure in 0.7% and 10.5% of all cases in the ICRT group compared to the TCRT groups, respectively, p-value of 0.001. The total implantation time was 81 minutes in the ICRT group and 83 minutes in the TCRT group. Time with catheters in the coronary sinus was 45 minutes for the ICRT group versus 37 minutes in the TCRT group, respectively, p-value of 0.001. The authors conclude that ICRT, that is, using the sheaths provided by Merit Medical, did not prolong total implantation time despite longer time with catheters in the coronary sinus, and that approach allowed for achieving a more optimal lead placement approach compared to what their experience was in the earlier years using standard sheaths provided by the manufacturers. The title of the next paper is Inflammatory Biomarkers as Predictors of Systemic versus Isolated Pocket Infection in Patients Undergoing Transvenous Lead Extraction. The author is Anne-Sophie Lacharita-Roberge. The objective of this study was to determine if inflammatory biomarkers can help diagnose CIED isolated pocket infection. This is a retrospective analysis of 156 patients undergoing transvenous lead extraction for CIED infection at the University of California, San Diego between 2012 and 2022. Patients were classified as systemic infection, 88 patients, or isolated pocket infection, 68 patients. Preoperative procalcitonin, C-reactive protein, and white blood cell count were obtained prior to extraction, and they were compared between the groups. As a control, the authors also included 281 patients who underwent extraction for non-infectious reasons. The authors found that the systemic infection group had a higher PCT level than the control group, with a p-value of 0.001, or to the pocket infection group with a p-value of 0.009. However, there was no significance in PCT value between control subjects and isolated pocket infection subjects. Higher white blood cell count was only associated with systemic infection when compared with the control group. The authors conclude that in patients diagnosed with CIED infections requiring extraction, inflammatory biomarkers were not elevated in isolated pocket infection. Inflammatory markers are not predictive of the diagnosis of pocket infections, which ultimately requires a high level of clinical suspicion. The title of the next paper is A Targeted Educational Intervention Increases Oral Anticoagulation Rates in High-Risk Atrial Fibrillation Patients by Dr. Roop Dutta and colleagues. The purpose of this study was to examine if oral anticoagulation rates can be improved in AF patients using an educational interventional program targeted to primary care providers who are identified to have low oral anticoagulation rates. Primary care clinicians were stratified by proportions of their AF patients with elevated stroke risk who were not taking anticoagulation medication. The program consisted of an email messaging summarizing anticoagulation guidelines. Improvements in the use of oral anticoagulation were then compared to the clinics with the higher oral anticoagulation rates. Data from a 6-month lead-in phase were compared to a 6-month follow-up period. In terms of the results, there was a total of 141 primary care clinicians with patients who met the inclusion criteria. 36 patients, representing about 26% of the total group, were assigned to the educational group, and 105, or 75% of the patients, to the control group. At baseline, there was a significant difference in percent of high-risk AF patients who were untreated in the educational group, 20.65%, compared to the high-risk patients who were untreated in the control group, 13.64%. After the educational intervention, high-risk AF patients without anticoagulation decreased by about 16% in the educational group and 10% in the control group, with the greatest absolute reduction in the interventional education group of about 5% versus 4% in the control group. The authors conclude that a targeted education program was associated with increased anticoagulation rates for AF patients at high risk for stroke. The title of the next paper is A Randomized Controlled Trial of the Size Adjustable Cryoballoon versus Conventional Cryoballoon for Paroxysmal Atrial Fibrillation. The Contrast HRO2 Trial Rationale and Design. So this is a methods paper describing a study focusing on a novel size adjustable cryoballoon, Poole TM Fit, that enables delivery in a standard 28mm or expanded 31mm size. The purpose of the study is to perform a randomized clinical trial to evaluate the safety and efficacy of this novel cryoballoon compared to a conventional cryoballoon. The trial design is multi-center, prospective, open-label, and randomized, with a plan to enroll 214 patients with paroxysmal atrial fibrillation randomized 1-to-1 to cryoballoon ablation with either a conventional cryoballoon, which is the Arctic Front Advanced TM Pro, or a size-adjustable cryoballoon, the Poole TM Fit. The primary endpoint of this study will be the incidence of phrenic nerve injury. Secondary endpoints include procedural success, chronic success through 12 months, procedure-related adverse events, biophysical parameters during applications for each pulmonary vein, total procedural and fluoroscopy times, level of PVI and isolation area, and probability of non-PVI foci initiating AF. Well, we look forward to the results of this interesting study. The authors note as a background that the increase in implantation of CIEDs has been significant over the recent years, and therefore the incidence of adverse events is likely to increase, and that the implications of these changes are particularly concerning in rural areas of the United States, where public health challenges are frequent and access to specialized medical care providers may be limited. So the authors sought out to evaluate rural and urban disparities related to CIED mortality in the United States between 1999 and 2020. To do this, the authors extracted mortality data from the Center for Disease Control and Prevention WONDER database. The WONDER database is called Wide-Ranging Online Data for Epidemiologic Research, and spanning the years 1999 to 2020. The authors identified all decedents associated with ICD-10 codes of mechanical complication of cardiac electronic device, such as obstruction, breakdown, leakage, malposition, displacement, protrusion, or perforation. The authors collected demographic details from all included deaths, including age, sex, race, U.S. Census region, and information from death certificates. The authors calculated age-adjusted mortality rates per 1 million population between urban and rural areas, both cumulatively and across demographic groups. They also calculated rate ratios by dividing the AAMR of rural deaths by that of urban deaths. The key findings of this study were: 1, that rural populations have higher cardiac implantable electronic device-related mortality when compared with urban populations; 2, the abundance of tertiary care centers, cardiac specialists, and access to advanced equipment in urban areas are likely major factors contributing to this mortality disparity. And finally, further investigation into patient-level socioeconomic factors is warranted to understand its impact on this rural-urban cardiac implantable electronic device death disparity. The title of the next paper, which is a review topic, is Antiarrhythmic Effects of Metformin by Dr. Lorraine Maskin-Herrenhaus. The background is that atrial fibrillation is a major public health problem associated with stroke, heart failure, dementia, and death. Metformin has been prescribed as a first-line medication for treatment of diabetes, but may have antiarrhythmic effects. The authors in this article reviewed the clinical, observational, and experimental evidence for the association between metformin and cardiac arrhythmias. They also discussed the potential antiarrhythmic mechanisms underlying this association. They suggest that repurposing a well-tolerated, safe, and inexpensive medication to prevent cardiac arrhythmias has significant positive public health implications. The next paper is a brief report. The title is Racial Ethnic Differences in Patients Undergoing Left Atrial Appendage Occlusion by Dr. Robert Helm and colleagues. This paper explores racial and ethnic inequities associated with receiving a left atrial appendage occlusion device. The authors hypothesized that compared to white individuals, Black and Hispanic individuals have greater comorbidity burden by the time that they receive a left atrial appendage occlusion device, and that they are more likely, therefore, to experience in-hospital adverse outcomes. The authors sought in this study to determine these differences in the prevalence of comorbidities and in-hospital adverse outcomes at Boston University, using the National Claims-Based Premier Healthcare Database of individuals who received a left atrial appendage occlusion device between 2016 and 2020. The cohort of AF patients was identified using ICD-10 codes. The authors abstracted the information on baseline patient and hospital-level characteristics. Frailty was measured using claims-based surrogates. The study included 20,065 patients in the left atrial appendage cohort. 1.2% were Asian, 4.6% Black, 3.2% Hispanic, and 88% white. Black recipients were significantly younger. 44.3% of Black recipients were greater than 75, whereas the majority, or 61% of white recipients, were greater than 75 years. The percentage of women among Black recipients was higher than in any other racial or ethnic group. Black recipients were also more likely to have additional medical comorbidities. The key findings are, first, that the use of a left atrial appendage occlusion device is limited in Black individuals greater than 75 years of age compared with white individuals. Second, the percentage of Black women receiving a device was significantly higher than in other racial ethnic groups. And finally, that Black individuals were more likely to experience bleeding complications and most likely to receive warfarin plus antiplatelet agents than white individuals. The next paper is a Fellows Corner case series. I encourage you all to read this. The title is Beware of the Gift That Conceals a Blade, Case Series of Drug-Induced Torsade de Pointes in Patients with Multi-Drug-Resistant Tuberculosis Treatment by Dr. Anand Abhinav and colleagues. The next paper after that is two papers, actually, that make up our Perspectives in Contrast duo. The first is titled Rate Adaptive Pacing in Heart Failure with Preserved Ejection Fraction, Too Much of a Good Thing by Dr. Matthew Hyman. And the second is titled Accelerated Physiologic Pacing in Patients with Heart Failure with Preserved Ejection Fraction, an Argument to Support Therapeutic Heart Rate Modulation by Dr. Margaret Infeld. I encourage you to read these. They're always a lot of fun to look at the con and pro perspectives of different topics. Next up is a research letter. This is called Changes in Electrical Delay is Associated with the Hemodynamic Response to Cardiac Pacing. The first author is Dr. Stian Ross. In this study of 38 patients, the authors examined the electromechanical response to various forms of cardiac pacing, including right atrial, right ventricular, and bilead pacing, in an acute hemodynamic study measuring LV, DP, DT. The key findings are that 1. The time to onset of the steepest deflection measured with 2 electrocardiographic electrodes is a simple method for assessment of LV electrical dyssynchrony. 2. Reduction of ventricular electrical delay was a marker of favorable hemodynamic response to both right ventricular and biventricular pacing. And 3. That activation times routinely measured in conductance system pacing may provide valuable information also in conventional pacing. So this ends the May 2024 HRO2 podcast, and thank you for listening.